Good morning, all participants. My name is Dr. Hafizz from Prince of Songkla University. My topic today is a surgical treatment in chronic PCL insufficiency. Thank you for my advisor, Ajahn Chaiwat, Ajahn Vachirapan, and Ajahn Thanarat Krab. The anatomy of the PCL. The PCL is the largest and strongest interarticular but extrasynovial structure of the knee joint. It has two functional bundles, anterolateral bundle and posteromedial bundle. The biomechanics function of the PCL is primarily restrained to posterior tibial translation and secondary restrained to external rotation. The important role of the PCL is a screw hole mechanism. PCL acts as an axis of the rotation. The knee will be locked stable position by knee full extension. And to do that, during the terminal extension, from 30 degree to full extension, they need 10 degree for external rotation of the tibia. The mechanism of injury of the PCL, the dashboard injury is the most common injury and hyperflexion of the knee with ankle pentaflexion and hyperextension injury. There has many examinations for PCL injury and concomitant injury such as the PLC. A reverse Lachman test is a test of the PCL injury by applying a posterior force of the tibia by compared to the contralateral side. A posterior double test, the knee will be restored in normal position. Before the examination, the medial tibial plateau 10 mm anterior to the medial femoral condyle. A posterior double test can be grade 1, 2, and 3. Beware of concomitant PCL and PLC injury. Grade 3 always indicated combined PCL and PLC injury. A quadriceps active test is a more specific test for PCL injury. A posterior saxar is the most sensitivity for PCL injury. By lift the heel up and hip and knee are both flexed at 90 degrees. Look for the tibia step down. A reverse pivot shift test is a dynamic test for the combined injury PCL and PLC. And to evaluate posterolateral corner instability and lateral instability, can perform varus test and dial test, external rotation of the tibia at 30 and 90 degrees for look the concomitant injury PCL and PLC. Investigation for diagnosis of the PCL injury. A plain radiograph look for the bony avulsion injury or associated fracture injury. Stress radiograph is used in chronic PCL injury. Posterior translation of the tibia more than 8 mm is indicated for PCL injury. A kneeling film is a stress radiograph to evaluate the PCL injury. A standing full leg radiograph to evaluate the mechanical alignment in chronic PCL injury. The MRI may be found to have continuous PCL fiber after the initial injury. Abnormal signal and shape may be observed, and concomitant injuries such as meniscus, cartilage, cruciate ligament, and collateral ligament can be found. If normal signal PCL fiber, it can be found negative of diagnosis of chronic PCL injury. Stress radiographs are strongly useful in chronic PCL injury. So, what happened after the chronic PCL injury? As previous slide before, in the screw hole mechanism, both cruciate ligament will be tied in full knee extension. The PCL acts as an axis rotation of the knee. When we lock the PCL, the knee acts to do the opposite way to lock the knee without the PCL. The tibia will be internal rotate and make medial compartment overload, and finally produce the chronic varus OA knee. And this slide shows the event after PCL insufficiency. When we lack of the PCL, loss of the axis of the rotation, the tibia act the opposite way to lock the knee in the internal rotation. Loss of screw hole mechanism and make the medial compartment pressure overload. Finally, the knee will be chronic varus alignment and develop the OA knee. And this paper evaluated the long-term follow-up of untreated PCL injury in short-term, moderate term, and finally, medial compartment and patellofemoral compartment OA has been developed. And this paper showed the effect posterior cruciate ligament reconstruction on the patellofemoral contact pressure in the knee joint under simulated muscle load. In case of chronic PCL insufficiency, the red color shows the high contact pressure at the PF joint. In PCL deficiency, compared with the intact PCL and PCL reconstruction. The effect of posterior ligament deficiency or the knee kinematic. Posterior cruciate ligament rupture result in fixed posterior subluxation of medial tibial plateau. In this paper, showed degenerative cartilage lesion at medial femoral condyle and patella. After arthroscopic evaluation at 5 years after injury, cartilage lesion at medial femoral condyle and patella was 70% and 40% orderly. And this classic paper, the Jew was published in 1988, The Natural History of the PCL Insufficiency in three phases. The first is functional adaptation in T to 18 months. The second is a functional tolerance continued for 15 to 20 years. And finally, osteoarthritis change after 25 years. In conclusion of chronic PCL injury, posterior translation of medial tibial plateau, medial compartment pressure overload, and develop medial compartment osteoarthritis. The patellofemoral joint osteoarthritis. And finally, chronic varus OA knee had been developed. The treatment of chronic PCL injury was shown in paragraph. In paragraph can conclusion management of chronic PCL insufficiency. In chronic PCL grade 1, grade 2 can be managed by conservative treatment. Chronic symptom PCL grade 3, posterior tibial translation more than 10 mm can be managed by arthroscopic PCL reconstruction. And finally, if patient have malalignment or osteoarthritis change, the corrective osteotomy or arthroplasty can be chosen. The chronic PCL insufficiency can be concluded as a conservative treatment and surgical treatment. In chronic PCL injury, as we know that patient may have the medial compartment arthritis, PF joint arthritis, and chronic varus OA in the knee. In this symptom can be symptomatic treatment by offload medial and PF compartment, improve function by rehabilitation, weight reduction, and prevent further damage. Conservative treatment of chronic PCL injury grade 1 and grade 2. Hyperextension of the knee and posterior tibial translation should be avoided. Hyperextension and hamstring exercise is prohibited for the first phase. The balance and proprioception training, quadriceps and gluteal strengthening exercise must be done in conservative treatment. Non-surgical treatment has high level of satisfaction and return to sport, and no correlate between knee laxity and subjective knee score. The point of concern of surgical treatment in chronic PCL injury, the instability of the PCL and concomitant PLC injury, the alignment and osteoarthritis change. In case of instability without the abnormal alignment and severe osteoarthritis, we choose the PCL reconstruction, the posterior tibial translation more than 10 mm. The PCL reconstruction could be chosen. There is variable technique and still no gold standard. For the graft choice, there is no consensus of the graft choice. The ideal graft property are those that simulate anatomic property and that the native PCL, including the size and geometric shape. In my institute, use both hamstring graft and bone patellar tendon bone graft. The graft size for the PCL reconstruction, optimum autograft from 8 to 10 mm. For approach to the posterior compartment, Ajahn Dr. Bancha proposed technique in ISACOS 2023. The advantage direct visualization of the posterior compartment. It can be performed visualization of the PCL reconstruction easily. And single bundle or double bundle reconstruction of the PCL. Double bundle PCL reconstruction demonstrate better objective posterior tibial stability, but not different in clinical outcome. Tangential or tibial inlay. Tangential, it can develop a killer turn. Tibial inlay is limited by open approach technique, but no any clinical or biomechanical difference between tangential and tibial inlay technique. So how to avoid a killer turn? A killer turn is an angle between graft tibia and femur. To decrease a killer turn, use a wraps or chamfering technique to decrease acute angle and graft abrasion. Move vertical, more vertical and center of the tibia tunnel, it can decrease a killer turn. And this technique by Ajahn Thammassat, proposed in 2021, is the same principle to avoid the graft abrasion by portal graft pass with bone patellar tendon bone graft, by shuttle graft to femoral and tibial tunnel, by portal techniques. It can decrease graft abrasion during passing the graft. Ajahn Bancha also published this paper in 2017 of remnant preserve of PCL reconstruction by septal rod pulley technique. It's same principle to avoid a killer turn, and remnant preserve can keep mechanoreceptor, proprioception, and sensation. The remnant removal has a good visualization, accurate of-tunneling, convenient graft paths, but at 2 years after reconstruction, a joint position not in the same level. And this paper shows remnant preserve and remnant removal. The study showed clinical result, no significant difference. But in remnant preserve, it's better in terms of improved healing by rehabilitation and recovery time. The augmentation with internal brace or PCL reconstruction is significantly decreased posterior tibial translation compared with the PCL reconstruction alone. If the chronic PCL injury develop the chronic varus or any, the alignment must be correct. HTO can be correct in the coronal plane and sagittal plane. In coronal plane, the mechanical axis should be passed at the center of the knee joint. Don't exceed to the Fujisawa point. In sagittal plane, tibial slope is the angle between of longitudinal tibial axis line and medial tibial plateau joint surface line. It varies from 2 to 10 degree posterior tibial slope. This paper evaluated the effect of the tibial slope. Biomechanics study after tibial flexion osteotomy, it showed increase of interior tibial translation. It decompressed of posterior medial tibial plateau. A tibial slope for stability of the posterior cruciate ligament deficiency. When increased the tibial slope, it significantly reduced posterior sag and improved posterior sag under axial load. In PCL deficiency, found 31% failure of the PCL reconstruction associated with varus malalignment. Prefer two-stage corrective osteotomy to correct the alignment and PCL reconstruction. So, how much to correct the tibial slope? Until now, there is no evidence of posterior slope. In opening wedge osteotomy can increase posterior tibial slope to 7 degrees. In patient eventually has the severe osteoarthritis in medial compartment or tricompartment osteoarthritis, the UKA or TKA may be chosen. So, in my conclusion of surgical treatment in chronic PCL insufficiency, instability managed by PCL reconstruction, and don't forget look for the concomitant injury. If malalignment can manage by corrective osteotomy, if patients still have the instability, can choose state corrective osteotomy followed by the PCL reconstruction. And finally, if patient has a severe osteoarthritis, can manage by arthroplasty. For the take-home message, for the treatment of the chronic PCL insufficiency, after chronic PCL injury, the instability, concomitant injury, alignment, and osteoarthritis must be addressed. Thank you for your attention.
You make decision between the conservative treatment and the surgical treatment by using the grading of the PCL injury, right?
Yes, yes.
As grade 1, we do conservative treatment for the grade 3, the surgery. How the grade 2 slide make decision to do the conservative treatment for the grade 2. But the problem is that how you clarify this grade 2 or grade 3, because it can make your decision besides just translation.
As we know that the grade 2 is posterior translation 6 to 10 millimeter, and if patient have the athlete patient or young patient, we consider to the PCL reconstruction. If patient have the laxity, yes.
So it means that you just look how translation you feel just 5 to 10 millimeters get through, then 10 millimeters can do surgery. Anything else, just because it's quite subjective, right?
Yes.
So in grade 2, some patient, some doctor gonna do surgery, but in your opinion, you say that grade 2 you do conservative. So my question is just anything else, because it's the part to make decision, right?
Yes. As we know that this clinical is by the posterior double test at 6 to 10 millimeter, but we have the stage film to evaluate the degree of the posterior translation of the tibia. When if we have the objective to the design the posterior translation, and we can go to the PCL reconstruction.
I would like about the PCL reconstruction in terms of the graft choice. So what is an ideal graft to do PCL reconstruction in your opinions?
In my opinion, is as we know that when we prefer to PCL reconstruction, we must restore the kinematic of the PCL, and my opinion is we restore of the footprint of the coverage of the footprint of the femur and tibia. And my opinion in my institute use the autograft of the hamstring and patellar tendon bone graft.
Do you think it's enough for the hamstring for that?
Maybe it's
for example, like you see some cases you harvest hamstring and you quadruple them up and it show up like 8 mil. Do you think it's enough? Will you do anything with that situation?
Yes, some patient is small size of the hamstring graft. Maybe we can use the option is a peroneus longus graft to the reconstruction of the PCL.
So you don't know until you know harvest it, right?
Yes.
So you're gonna harvest 2 grafts?
No.
Maybe
we use the internal breast augmentation for the PCL reconstruction.
So the answer should be like the ideal should be strong.
Yes.
Strong graft, big,
Yeah.
as big as possible.
Yeah.
So anyhow you fight to get that way. Okay, thank you.
Chronic PCL. What is your judgment between the sagittal plane alignment according to the tibial slope? Like you perform both of the PCL reconstruction plus the to making a different slope osteotomy like that. What is the indication for doing that?
In the indication in sagittal plane, right? If as we know that the posterior tibial slope has varied from the 2 to 10 degree. Until now, in the recent study, is no consensus of how much to correct the posterior slope. But we know that if the patient have the increase of the tibial slope, it can increase the anterior tibial translation.
My question is that which one that you choose between perform the PCL reconstruction alone or do just the tibial slope osteotomy or do both?
If patient have the malalignment, is varus alignment more than 5 to 10 degree, we choose the corrective osteotomy. But in my preference, I choose the osteotomy. If patient still have the instability, we stay to the PCL reconstruction.
It will be the stage. It's not the simultaneous for the same times.
Yes.
Correct?
Yeah.
So, how can you improve the outcome of PCL? Because you know the PCL outcome is not like ACL.
Yes.
Okay, you have any recommendations?
As I mentioned at the slide, for the graft choice, as Ajahn Chanakan said, the big graft, strong graft is okay for the PCL reconstruction. And for the killer turn, if we use the tibia technique,
Big graft, how big?
maybe
And
10
where-
or 11.
Where's your graft show? The big graft will be allograft, right?
Yes.
But you don't have allograft.
Yeah.
So,
I think it's a folding of the graft.
and how about your length?
Length
You
is
want to make it big, but how about the length?
maybe to 38 or to 40 millimeter.
40 millimeters
Yes.
diameter,
8 to 10 millimeter.
8 to 10.
Not diameter, length.
Shortest.
Yeah.
Shortest is,
38 millimeter.
I mean, after you double or quadruple.
Quadruple.
And how about the length?
The length of the
8, 9, 10.
maybe 8 to 10. The length,
Diameter
diameter is 8 to 10 too.
8 to 10 is
Nice.
too. Why? You say 8 or 9 or 10 or what?
maybe 8
8, no, it's too small. Thank you, thank you.
thank you ครับ